Welcome back, everyone. We'll be starting with our next session policy, and I would like to welcome Dr. Raja Narayanan and Dr. Brijesh Thakur on stage to moderate this session.
Can we have the video, please? So, good afternoon, everyone. Welcome to the post lunch session. In fact, the last session of the conference. It is my honor and privilege to welcome Dr. Vipul Agarwal, who is Joint Secretary in the Ministry of Health and Family Welfare, and also is the Secretary of the National Medical Commission. A huge workload that he is uh, taking and contributing right now. Uh, He's also a friend, knowing him since his days in MBBS at Maulana Azad Medical College. So he's a doctor, but then decided to move on to the civil services. He's an IPS officer from the Gujarat cadre. And I would say that we have been fortunate as a country to have a doctor in this position right now, that, people who have the expertise and knowledge guide us. And he actually was the deputy CEO of National Health Authority, which we all know famously as Ayushman Bharat. And then he moved on to do an MPH at Harvard University, which he completed this year. And now he has joined back the Ministry of Health. And Vipul, Dr. Vipul Agarwal would be talking today on universal health coverage, which we have been all discussing. And we would now request Dr. Vipul Agarwal to share his presentation and give his talk. Over to you, Dr. Vipul.
Thank you, Narayanan. Thank you, LV Prasad Eye Institute, for extending the invitation, and thank you for the warm introduction and welcome. I'm sorry I was given this invitation almost 3 months back, but and I had promised Narayanan that I'll be making it there, but somehow, as happens in government, we are not the master of our time, so I could not get the permissions because we are now on the field. All of us, in fact, the entire ministry is now there on the field to take a review of Ayushman Bhav campaign that we are holding across the country these days. And also tomorrow we have Swachhata Hi Seva campaign for which we also have to be participating. So as Narayanan told, I would be discussing on the very important policy aspect of universal health coverage that we've been talking since several years now, and where do we stand in India in terms of the implementation? What are the what are the pillars on which India is implementing this program, and how much do we still need to do to achieve the universal health coverage? So, if we go by the WHO definition, UHC, as we know, would mean that all individuals and communities get access to all the essential health services. These are the important aspects of this WHO definition, and the main objective is prevention of financial hardship. And of all the sustainable development goals, three which come under the good health well-being, I think the overarching target is the achievement of universal health coverage. India committed itself to achieving universal health coverage for all citizens without any financial hardship in the year 2017 through its national health policy. And the objective here again is to reduce inequities and also through it achieve social and economic development. And all this is coming through the basic right to fundamental right to health and life to live with dignity enshrined in the Article 21 of the Constitution of India. So most of us would be aware of this famous WHO cube. So when we talk about this cube, there are three aspects. If we see the current pool funds, any country would be having three decisions to make: whether they should use the funds if to expand the kitty of the population which is to be covered. Then second, which basket of services should be provided to the citizens. If we expand the basket, which services need to be included in case we have additional funds and we target for the next phase. And third is like which costs have to be covered. So direct costs as a proportion of the total costs, and how to shift from out of pocket payment toward a prepayment mechanism. These are the decisions, important decisions that any country, India being a developing nation still, we have to take these decisions, and those are very, very important. So if we say the vision of UHC would have every citizens must be entitled to the basic primary, secondary and tertiary healthcare. And the national health package, which is required to cover all conditions, would differ from different countries based on the priorities that the government sets for itself. And so the decisions that we are making in the universal health coverage agenda would be to give entitlement to all citizens, and like how many citizens, what section of the citizens to be covered there. What should be the components of national health package, health benefit package? Would that be an essential benefit package for all citizens, including the primary, secondary, and tertiary component? Or we give the importance primacy to the primary health component or the secondary, tertiary? So that is another aspect to it. And the citizens should be entitled to have a right to choose between the public and private healthcare providers. And through all these efforts, we intend to achieve the financial protection, job security, equity, reduction of poverty, greater productivity, and transparency and accountability. So we see the journey of India starting from 1946, when the Bohr Committee recommendations came towards providing a national health services. We have come a long way, and in the last decade or so, we have taken multiple decisions, and including the major 4 pillars of Ayushman Bharat that have been implemented in the recent times. So when we started Rashtriya Swasthya Bima Yojana 2008, it formed the basis for our national health program for the secondary and tertiary component, as Narayanan just told, the Pradhan Mantri Jan Arogya Yojana, which is the largest of its kind scheme in the world. And then in 2018, along with the PMJY, we decided to implement another primary healthcare component of Ayushman Bharat Health and Wellness Centers. And recently in 2020, we introduced the digital health program, again, that might become the biggest of its kind in the world, that is the Ayushman Bharat Digital Mission. And recently, the year before last, we launched the national program for infrastructure development, that is the PM Abhim, the Ayushman Bharat Health Infrastructure Mission. So starting with the primary, secondary, and tertiary components. So these two programs are essential pillars of our our Ayushman Bharat program, the health and wellness centers. So through this program, we wish to aim to provide broader range of healthcare services. So we've been having a network of primary healthcare centers in the country, which provide primarily primary healthcare for maternal and child care and communicable diseases, but expanding that kitty of services through the health and wellness centers to provide 12 kind of services, including mental health, including geriatric care, palliative care. So we have launched this program in a big way. And the target was to reach to a figure of 150,000 health and wellness centers towards the end of the last academic or last calendar year, and we achieved well before that. And that is the first pillar of Ayushman Bharat, to provide the primary care to, and that is a universal program, not limited to any particular section of the society. And the second component was Ayushman Bharat PMJY, where we have a beneficiary base of 540 million, to which we are providing a healthcare cover of 5 lakh per family per year for the secondary and tertiary hospitalization care. And this is taking care of the bottom 40% poor population of the country. And we are using a specific database, the socio-economic caste census of 2011 as the ground. So through these two programs, we are intending to cover the primary, secondary, and tertiary care. And this started in a major way the national program for the universal health coverage in a systematic way. So starting with health and wellness centers, this is the current network. In fact, this is the 2021 situation. We have now achieved the target of 150,000. I think we are standing at 194,000 now. And also the intended objective is to create linkages, backward and forward linkages with the primary and secondary and tertiary care component provided through the PMJY scheme. So although this chart on the left side is the objective to achieve the continuum of care is the objective of the program, but and it has been already decided, but probably the implementation at the ground level is still yet to be 100% complete. So we intend to create a referral system, both forward and backward referral system, so that each citizen is entitled to and we are able to track the life cycle of disease of any citizen who is covered under the scheme. Talking about PMJY, as I mentioned, it is the largest healthcare service, public funded healthcare program for secondary and tertiary care anywhere in the world. We are covering 11 million families. There's no cap on the family size, as against the RSBY scheme, where we had a family cap of 5 persons per family. And it was observed that most of the benefits of the scheme are being taken by the male members. We have removed the cap on this scheme, so family size can be anything, and we are not calling it family, we are calling it household. So there might be 2 or 3 families staying in the same household. So that is the definition we are using here, covering 40% bottom population as per the socio-economic caste census data, and almost all the secondary and tertiary component of care, including even the transplantation surgeries, are being included in the scheme. So under the scheme, we are providing 3 days pre-hospitalization up to 15 days post-hospitalization care to our beneficiaries, and everything is cashless and paperless under the scheme. So this is the feature. Almost we have around 27,000 empaneled healthcare providers through which we are providing the scheme, and the patient can go anywhere across the country without any geographical limitation of states. That used to happen when the states were implementing their own schemes. So this scheme is a scheme which provides benefit across the nation in the empaneled healthcare providers. So under this PMJY scheme, so far we have already achieved almost 250 million cards have been created out of the 540 million beneficiary base that we have. Almost 28,000 hospitals have been empaneled, and 56.3 million hospital admissions have taken place. So except for Odisha, West Bengal, and Delhi, almost all states are providing treatment under the scheme. So taking as the pillar for UHC, PMJY, strengthening of this PMJY scheme is very, very important, because unless we have a very strong secondary tertiary care component, India felt that although many countries feel that strengthening of the primary healthcare segment might be more important, India decided to go for a parallel arrangement of strengthening the primary as well as the secondary tertiary component. So still lots needs to be done to strengthen it. We are working towards convergence of fragmented healthcare schemes. So multiple schemes have already been onboarded to PMJY platform, and we are trying to create linkages with those schemes so that we get the beneficiary data, and multiple benefits being availed by a single person can be done away with. At the same time, we have uniformity of care across various schemes. We also need to leverage the health digital health stacks like EHRs to improve the health system efficiencies. Recently, ABDM has acted as a force multiplier, and we are using PMJY with the support of ABDM platform to strengthen the service delivery under PMJY. We are also working to expand the beneficiary base. In fact, many states have expanded the beneficiary base to use the NFSA data and other databases to cover larger section of population. And we recently have taken a decision in PMJY also to allow those databases to be used for identification of beneficiaries, so that we reach to maximum utilization under the scheme. And as I mentioned, continuum of care is the ultimate objective, because unless The beneficiary is tracked through the life cycle of disease till the patient is referred to a higher center and then back referrals to the primary for follow-ups. The scheme cannot achieve the desired objectives. So, talking a bit about Ayushman Bharat Digital Mission. So, this digital program was launched in the year 2020 and 2021, and this includes inclusive, accessible, affordable, and efficient digital health infrastructure is the objective. And we want to create a healthcare ecosystem. So, and data information is accessed by all stakeholders across the ecosystem. So that we are using multiple registries under the scheme. The most important and the core component is the ABHA number, the Ayushman Bharat Health Account Number, which is a 14-digit identifier to identify all the citizens. So almost 45 crore citizens of the country have already got their ABHA numbers. And we have created an ABHA app, which is a very, very easy to use app. And all the ABHA IDs are getting linked through Aadhaar, so that easy retrieval and usage across various schemes becomes easy. We have also launched a healthcare professional registry where almost 2.29 lakh healthcare providers have already been onboarded. And we are giving a 14-digit identifier to even the professionals. The health facility registry would link all the health facilities where, based on consent, the data can be transferred across the health facilities. So more than 2 lakh health facilities again have been onboarded here, and each facility is given a 12-digit identifier. And the component of drug registry is being slowly built up, where we are uploading a list of verified drugs, and drugs and strips can be identified. This is something that we are working on. So through these registries, the ABHA number ensures that there's an easy registration of the beneficiary and exchange of health records become easy. The consent-based sharing, the consent architecture and federated system of storing information is the key to this, so that the data resides at the place where the data is generated. And the consent-based sharing, so the person whose data, for example, if it is my health record, I would have the right to allow that data to be shared between the healthcare providers. So this is the key aspect that we have built into the system. And the healthcare professional facility searching becomes very, very easy in this. And we have used a very democratic system. There's nobody, like if you use an engine like Google, so if you pay more, then you can show yourself at the top of Google search. Whereas in ABDM, we have ensured that it's a democratic process, and only alphabetical search of various providers and other facilities is possible here. So for the professionals and healthcare professionals and the health facilities, they can it ensures the ease of doing business and remote access to the patients, and medical histories, medical records can also be accessed remotely by the healthcare providers, and organized consultations and diagnosis can take place through this. Apart from this, the interoperability and anonymization of data ensures that drug supply chain management becomes easy. So we are working on this, although this is not developed to full, but yeah, so we are working to expand the network to ensure better drug identification and supply chain management of drugs. At the same time, so we have recently built a health claims exchange platform. So what happens in a hospital if we are working with 10 different insurers? The hospital has to maintain a dashboard and software for entering the claims for each and every provider. So we have recently launched a health claim exchange where a single screen you can enter the claims for all providers, and through this health claim exchange, the reimbursement can take place. It is a very, very seamless and smooth system that recently has been implemented. And so major diseases and symptoms can be identified easily, and better policy decisions can take place. So the last component of this series of Ayushman Bharat schemes is the Ayushman Bharat Health Infrastructure Mission. So it has two components. This is basically aimed to improve the healthcare infrastructure primarily in the tier 2 and tier 3 cities. So it has one centrally sponsored component where center is giving grant in the ratio of 60-40, 90-10 or 100-0 for different categories of states. Whereas the central sector component, 100% is funded by the center. So through the center sponsored scheme, we are providing support to rural healthcare, health and wellness centers, urban HWCs, the block public health units, in focus areas, and also setting up integrated public health labs in all districts. Whereas the central sector component is taking care of the central institutions to convert them into training and mentoring sites for strengthening of NCDCs, the expansion of health information portal so that to connect public to all the healthcare labs. Then again, operationalization of new public health units, and strengthening 33 existing public health units at the point of entry, and setting up of emergency health operation centers in various states. Towards the end, this is the last slide of my presentation. So far, we have tried to achieve the objective of providing the healthcare to the with the aim to achieve 100% primary coverage to all the citizens, whereas we have used a targeted approach for the secondary and tertiary coverage. And while we are looking at the demand side strengthening, we have also tried to do the supply side by improving the healthcare infrastructure, and also ensuring that the digital backbone supports the entire objective. But still, there's a lot to be done on which we need to work, and the governments are working to achieve that. So another aspect that we are seriously thinking about is how to cover the left out population. So PMJY is covering around 40% population, and if we add the state beneficiaries which have been added through the state support in different states where the scheme has been expanded, still around 50% of Indian population is left out. So they are not having any coverage for the secondary and tertiary care. So how to cover that? Whether we need to provide them 100% reimbursement for care, or we need to do a co-payment mechanism wherein a part of their treatment can be funded by the government and part has to be taken care by the beneficiary. Or government can do a negotiation with the hospitals and reduce the cost of treatment for them, and charge some amount as annual contribution from such middle class to upper class population. So that is something that we are working on. Similarly, how to expand the service coverage, whether this cap of 5 lakh rupees per beneficiary is sufficient, or we need to improve on that. Many states have recently expanded it to 10 lakhs. Even Gujarat, states like Rajasthan have done that. But that is something, if we have to do that at national level, we need to do some thinking and homework, whether that would really be required or not at the national level. So that is again an objective that we are working on. An important aspect is how to improve the human resource for health, and how to have a better upgradation of the skills of the human resource that we have. This would not be limited to only the medical staff. This would also extend to the paramedical and support staff. So this is something which we are still working on. So we have increased the number of hospitals and the medical seats in the recent times. So, but we still have a lot of gaps, especially in the rural areas and in the central Indian belt and states which have a real deficit. So this again is a focus area for us. So as I mentioned earlier, we need to decide whether we should need to continue with the same scheme of providing the primary healthcare through the health and wellness centers, where in the primary healthcare program we don't have so far the contribution of the private sector. So do we need to involve the private sector? How to strengthen the primary health coverage, or we need to continue the way we are doing, taking parallelly the primary healthcare with secondary and tertiary? So this again is something that I feel we need to have better work on. And finally, how to strengthen the procurement and supply chain, because almost 60% of the out-of-pocket expenditure on healthcare is happening on the medicines, and most of that is in the primary care segment. So this again is a challenge for us. And alongside the health, a well-functioning health information system is what we want. So taking all this into consideration, I think we are on track. We are working in the right direction. And if we continue like this in the next 3 to 4 years, I think we would be reaching close to what we can call as UHC in the Indian scenario. I don't think that the top 10% of Indian population would require to be funded by the government. They might be well off. They might not be requiring any coverage support. But yeah, so how to cover the rest of them is something that we really require to work on, and we are sincerely working to frame the policy guidelines for them. So this is something which is the target for us. And I think we are on it. Thank you very much.
Thank you so much, Vipul, for that excellent and comprehensive presentation. In fact, you covered quite a few sessions that we have had since the last 2 days in our conference. And many questions we were discussing and debating about Ayushman Bharat and India's health systems improvement. What all can we do? You have covered many aspects in your talk. And I know the audience has a lot of questions, but I would have Dr. Aparna Mittal to ask the first question, and you can speak from there if you wish. Yeah, it's on.
All right. So I'm Aparna Mittal from Patients Engage. Thank you. I think it's a great presentation, and as Dr. Raja said, it covered a few points that I had, especially on the missing middle. The one point that, because we work on the space of health literacy for people dealing with chronic conditions, patients and caregivers, and because we do believe that 95% of chronic disease management happens outside the clinical arena, what I think we probably are not seeing in the presentation is the effort on building health literacy so patients and caregivers can become partners in care and manage their conditions better. So I think, is there any plans on that? That was a question that I had.
Yeah, so regarding the health literacy, as Dr. Aparna, thank you for this question. We very much acknowledge that health being a state subject. We are doing a lot on the primary healthcare segment, which includes many states are working on that, and the PIP which is sent for the NHM. So many states are including a component of health literacy and capacity building of the functionaries at the ground level. But yeah, so at the national level, health literacy as a scheme, we might not have launched so far because we want to give more flexibility to the state to decide what the priorities are. There might be some states which are well ahead of the other states in the country. We talk about the southern states, they might be much more awareness in terms of their healthcare requirements in the southern states, and they might be the people. I went to Goa yesterday. I think people are so demanding there. They might not be having the same requirement as somebody in a state like Bihar or UP would be having. So we are leaving it to the states to decide as to how much would be the healthcare requirement, how much budget had to be allocated for that, and how we have to take care of that. But the point well taken. Yeah, so and since I am not directly dealing into the primary healthcare aspect, I currently am in the medical education segment, and till very recently I was handling the secondary tertiary component. In PMJY we do have a very strong capacity building arm. We are taking support of our international partners, development partners also in creating awareness, because unless we build up a very strong network of our trainers and awareness campaigns around the health demands and health requirements, the health seeking behavior would not come. So I think those things are very important on the ground, and as a program, yes, I would convey your thoughts to the people who are handling the primary healthcare segment to do something on this at the national level in terms of a policy guideline.
Thank you.
Thank you so much, Vipul. Do you have time for one more question?
Yeah, obviously. I do have time till 2:30, yeah, so I can take more questions.
Yes. Thank you, Dr. Vipul. So, the question was that you are the best person to know why primary health coverage or secondary health coverage could not do as well as we all wanted it to. So now we are introducing a new thing, EHWC. So, what are our learnings from those failures, and how are we going to take those learning forwards to prevent the HWCs going the same path?
Yeah, so thank you for this question. So Health and Wellness Center is not only not only an infrastructural change that we are doing here in this. So we very much understood and assessed the failure or our primary healthcare program where we were not able to achieve the intended outcome out of that. So we were earlier targeting, one was the doctor-centered approach that we had adopted. So we felt that we are not using the capacities of decision making at the ground level in terms of a team-based approach. So I think that is a major change which has come in the thought process, and Health and Wellness Center approach apart from including the 12 aspects instead of the 6 primarily aimed at maternal and child health in the previous setting, we have now included mental health, geriatric care, palliative care. So those are the components that we've included, but we have changed the way the process is working on the ground level. So decision making, probably now we are giving more power empowerment to the local health and wellness center to take decisions about what is the best in their catchment area to work on. Second, the entire team would work on those lines. Plus, the review mechanism have become more stringent now. The states are being regularly, the reviews that we used to have at the primary healthcare, those times were different. Now the awareness also is increasing about health, and PHCs getting converted into health and wellness center is not only a change in terms of the expenditure or the expansion of services. We are changing the way the functions of the things are taking place. I see that there's a lot more stringent review which is happening on the ground. To immediate corrective actions are taken. The states are constantly being communicated on the failures or not achieving an intended benefit. It is not an annual review or annual, just somebody is preparing a PIP and that time we are reviewing it. So it is happening on a month on month basis. So those things have changed. Our interaction, the mechanism of interaction has changed. The empowerment has, and the states have become more proactive in their approach towards the primary health coverage, because primary health coverage now is a well settled phenomena here. When we established PSCs, we were in the initial phase of it. So I'm very hopeful that we whatever mistakes happened earlier would not happen now, because we have learned and this has gradually evolved over the years.
Thank you, Vipul. Are there any other questions from the audience? I have one comment slash suggestion, Vipul. So you mentioned that you're trying to increase the coverage beyond the lower 40%, and you mentioned about the top 10% may not require this kind of support. But I would like to alert, based on some data that we have captured at LV Prasad Institute, that is the old population. We looked at young old and older old, that is above the age of 70. The risk protection population which has risk protection above the age of 70 is so low, irrespective of whatever their education or past employment status or and if you look at percentage wise, above the age of 90, it's just close to 1% who have any kind of protection. 99% have no health protection. And even above the age of 70 to 89, it's about just 5% or 6%. So 95% of that population not earning, doesn't have any insurance from even private insurances, refuse insurance for them. And that's a vulnerable age. And now we also know that many of them are not living with their families, kids are staying somewhere. But that's something we would like you to keep in mind whenever you're looking at prioritization of the riskiest population which needs to be covered. That's just one comment I had.
No, thank you. That is very important. In fact, that the coverage of geriatric population and the population which is at risk in terms of like the weak section of the society. So those are special groups for which we would definitely be, because this was when I was working in NHA, we had a long discussion on providing a cover or a special scheme for the geriatric population for the secondary and tertiary coverage with the Ministry of Social Justice, whether they can sponsor that scheme, and we launch it on our platform. So those are and there's also a very serious thinking going on. We launched our missing middle pilots on and we issued an expression of interest wherein almost 18 insurers provided their interest, showed their interest in providing low cost products for even the middle and upper class population. So we are seriously thinking as to how to expand the coverage, at the same time not leaving any vulnerable section behind. So it might be a coverage considering the constraints of budget that we have, we might be gradually progressing. But at the same time, the priority population, the vulnerable population does not have to be left behind. That is very much in the agenda. So we would ensure that even those who are well off, but at the same time very vulnerable, might not be getting the coverage or be able to get the coverage despite their economic status. They need to be provided adequate cover. That is very much in our scheme of things.
Thank you so much, actually, for clarifying that point, people. And we would like to sincerely thank you for taking time off from your busy schedule to participate and give us your talk today. Thank you so much, people.
Thank you, Narayan, and thank you to all for giving us the invitation. Thank you very much. Yeah, namaskar.
Thank you so much.